Good evening, everyone, and thank you for joining us today. My name is Brooke Boring, and I am HOPA's Senior Manager of Health Policy and Advocacy. It is my pleasure to welcome you to HOPA's annual Advocacy Update. Before we begin, I wanted to share a few reminders. Full speaker bios can be found in the virtual environment. Under the Event Resources tab, you will find the slide deck for this presentation, as well as PDF documents of two of the projects the Public Policy Committee worked on over the past few months. Text chat and Q&A is also available. We will be having a live Q&A at the end of the session, so please submit your questions throughout the presentation. I would now like to introduce today's speakers. The chair of the Public Policy Committee is Dr. Mark Hamm. Dr. Hamm is the Director of Oncology Pharmacy Services for Advocate Aurora Health in Wisconsin. The Vice Chair of the Public Policy Committee is Dr. Kathyrn Schultz. Dr. Schultz is a Medical Science Liaison for Malignant Hematology at Genentech. HOPA's Government Relations Consultant is Mr. Jeremy Scott. Mr. Scott is a Senior Vice President at CRD Associates. He has been representing HOPA in Washington for over a decade. Here are our disclosures. Dr. Schultz is the only speaker with a disclosure to report, as she is an employee of Genentech. Without further ado, I would like to hand the presentation off to Dr. Hamm, who will explain more about the Public Policy Committee and their efforts during this committee year.
Thank you very much, Brooke. Well, to begin, we'll just start by outlining some of the objectives of what we hope to cover today. So the first is just providing an overview of what the Public Policy Group works on, what our agenda is, and some of the activities that we've worked on throughout the course of the year. Then introducing some of the who's who of the Biden Administration and Congress, which will be covered by Jeremy, providing an overview of evolving congressional landscape, and then describing the current state at the federal level for some of our key legislative initiatives. Moving into this then into just more about HOPA and what our policy agenda is. To begin, I'd like to thank our Public Policy Committee this year. So on the screen, you should be able to see our members this year. We've had a great year with a lot of terrific discussion, and this is a group that you get to discuss things that you see semblances of in your day-to-day, but certainly at a different level in detail than at least I would otherwise get to be involved with. So really appreciated the discussion that we've got to have through the year, and would also like to thank Brooke for help steering the ship throughout the year. So what is it that we cover within this group? We have two primary charges that we're tasked with covering throughout the year. The first is promoting and improving patient safety by really helping others realize the value that we bring as pharmacists to our cancer patients. Some of the ways that we'll talk about doing this year has been what we'll talk about with the value of the Hem/Onc pharmacist paper that was written and submitted, and then also some of the activities that you'll hear with what Jeremy and Brooke are doing with different coalitions and what they're doing to promote our agenda there. The other large one is around oral chemotherapy and making sure our patients have appropriate access and are being treated safely with these drugs. Another longstanding topic related to oral chemo is oral chemo parity and making sure that our patients have financial access to these medications. And no surprise, we'll talk about that later in our discussion today. As far as some of the activities that we've worked on this year, we'll highlight a few that are covered on the slide here. So the first is around the drug shortage survey. I believe it was in 2013 that a paper was produced by HOPA outlining just some of the key challenges that we've been having with regard to drug shortages in the oncology space. And thought it was time to update this since unfortunately drug shortages have not gone away. So at this point, we've administered the survey to the membership, have collected responses, and right now we've submitted an abstract to the ASCO annual meeting, and we're working on creating a publication that we can share the results with others from what we found. The next one is what I alluded to before with the value of the oncology pharmacist op-ed that was created. What this was created was really to highlight the value that pharmacists bring specifically in the world of drug shortages. And then as we were writing this, COVID happened. So trying to highlight where pharmacists play a role to maintain patient safety in both of those areas. It's very well done and posted on the website, so I encourage everyone to go take a look at it. But one of the things that we learned along the way is how we can share this with others. And we found a platform that we're able to share, and other media outlets can pick it up and can share it with others. And to date, it's been picked up 33 times, reaching an estimated 2.4 million people. So far greater reach than I think any of us expected going into it, but it's terrific that it's out there and we're helping the general public understand the value that hem-onc pharmacists bring to their patients. The next then is around issue briefs. So issue briefs are created at the direction of the board, and they're really intended to outline key issues that we want to keep tabs on, but to let us give our position on where we stand with the issue. So these are going to be things along the lines of biosimilars, drug waste, drug shortages are a few. But Kathyrn was tasked this year with working with the team to review the issue brief. So in time, they become outdated or they need updated. They may just not be relevant anymore. So they reviewed the 8 that we have on file and made recommendations to the board. 2 of them were elected to be sunsetted because they were found just not to be relevant anymore. And then 1 around pain management was updated and was approved by the board. So terrific work there, keeping everything up to date and on task. And then the last piece was around our 5 guiding principles that was created for COVID vaccine distribution and administration. The principles in this outlined topics such as equity, safety, the need for additional research and education, and then logistics that we had to consider as COVID vaccine was becoming a reality. And keep in mind, this was written prior to any vaccine actually being distributed. But this was shared with the Biden administration, the COVID-19 task force, and the CDC. So I hope that gives a reasonable idea of some of the great things that we were able to work on this year. Jeremy will go into a little more depth now as to some of the other activities that took place within the group.
Great. Thanks, Mark. It's a pleasure to be with you again. Unfortunately, this time virtually, but I always love coming to the conference and talking about what we've been doing in Washington. So thanks, Mark, for that update. So HOPA's advocacy efforts, as you all know, are around the sign-on letters, Hill meetings, regulatory comments, coalition engagements, monitoring, tracking, and then we usually hold an annual meeting. It did not happen last year because of COVID, but we are planning the board is planning to do one this fall. And all of that centers around the health policy agenda and those issue briefs that Mark just highlighted or outlined for you. That's sort of, as he said, our driving principles moving us forward. And so all of what we do, sign-on letters, our regulatory and our partners all sort of move our efforts forward. Next slide. Thank you. So I just wanted to talk a little bit and remind folks of the various coalitions that Brooke and I staff on behalf of HOPA. So the Cancer Leadership Council is made up of about 30 organizations, and they engage in a wide range of issues, but fundamentally what they focus on is ensuring that cancer patients have access to high quality care. The Cancer Leadership Council really seems to square in the regulatory space. We really lean on them for regulatory letters, comments on a broad array of cancer access issues. The next one is the Coalition to Improve Access to Cancer Care. And again, in full disclosure, I say this every year, I actually help run this coalition on behalf of the International Myeloma Foundation. But it is a patient-focused coalition made up of patient advocacy groups, healthcare providers, cancer centers and hospital systems, as well as the life sciences industry. And as Mark said, our focus has been on oral parity. And so this is what this coalition focuses on. And it's basically the driving force behind the Cancer Drug Parity Act to try to equalize and reduce the high out-of-pocket burden on cancer patients who are able to take oral chemotherapy as opposed to IV chemotherapy. And HOPA actually sits on the steering committee of CIACC. JCCP is a coalition that primarily Brooke staffs, but I kind of monitor as well, and she keeps me in the loop. But it's really made up of pharmacy organizations that are focused on really achieving what JCCP's vision for pharmacists practice is, and that's really patients achieving the optimal health or medication outcomes with pharmacists as essential or accountable providers within that patient-centered or healthcare team. And then we have the Pharmacy Health Information Technology Collaborative, which we call PHIT. Their primary focus is twofold, really: effective medication use, so to ensure the meaningful use of standardized electronic health records that support safe, efficient, effective medication use or continuity of care, and provide those sort of patient care services of pharmacists, sort of as the interdisciplinary patient care team again. And then our second one really is around the pharmacist's role in HIT, basically assuring that pharmacist's role in providing patient care services are integrated into the sort of national HIT interoperable framework. So that's what PHIT does. The Commission on Cancer is really staffed by HOPA. I don't staff that, so that's one that we HOPA is a member of the Commission on Cancer, but it's not something that Brooke or I staff. One Voice Against Cancer, or OVAC, is united really behind sort of funding increases. So the annual appropriations process that funds the NIH, the National Institutes of Health, the National Cancer Institute, the Centers for Disease Control and Prevention, as well as HRSA and FDA. So that's really the coalition that HOPA sits at, that really moves all those funding requests around cancer research. And then lastly but not least is HIPNIC, which is the Health Professions and Nursing Education Coalition. And really, again, this is another funding coalition that HOPA sits at. And they focus on HRSA Title VII and Title VIII programs of the Public Health Services Act. So that's the health professions, non-physician for Title VII, and then the nursing programs for Title VIII. Next series of slides are just sort of fillers, just to keep you informed on what happened last November and the changing, if you will, of the guard in DC in January. So obviously, we now have President Joe Biden and Vice President Kamala Harris who are running the executive office of the United States. And with that, the President Biden's healthcare team is made up of Javier Becerra, who is a former congressman and a former attorney general in California, not new to DC, not new to healthcare. So he's now the Secretary of Health and Human Services. Chiquita Brooks LaSure is been nominated. I think her hearing is coming up. She's not been confirmed as the CMS administrator, but she has been nominated. And then you have Dr. Walensky, who's the new director at the Centers for Disease Control and Prevention. And then at FDA, we have Dr. Janet Woodcock, who again is not new, probably not new to many HOPA members. She's been at FDA for a long time, serving in many capacities. She's acting commissioner at the FDA. President Biden has not nominated a permanent replacement or a permanent FDA administrator at the moment. Janet Woodcock is actually in the running, but he has not made that nomination public. And then, to continue with, you had obviously Dr. Francis Collins, who's the director of the National Institutes of Health. Dr. Anthony Fauci, who's been no stranger to any of us through the last year, was part of President Trump's COVID task force and is carried over. President Biden carried him over to his. So he's not only the chief medical advisor to the president, but still pretty hands-on as it relates to the COVID task force. And then you have Dr. Sharpless, who's the director of NCI, the National Cancer Institute, and then Jeff Zantz, who, again, who's not a stranger to DC and healthcare, who's sort of the COVID czar, if you will, for the pandemic and leading sort of the president's task force, if you will. So the November election had some consequences, if you will. So the Democrats retained control of the House, but lost a lot of key elections, which was a surprise to many. So therefore, reduced their margins of power to about 10 seats. So there's only a 10-seat difference in power currently in the House. The Senate switched from Republican to Democrat. I think it was a surprise to many. It was the Georgia special election that put the balance of power to the Democrats in the Senate, with John Ossoff and Senator Warnock winning both of those runoff elections. Even though the Democrats can control, the margins are very tight. It's a 50-50 split in the Senate, with obviously Vice President Kamala Harris being the tie-breaking vote in the Senate. So while the Democrats have control, they've swept the House, the Senate, and the presidency, their margins to move power or to move legislation is very slim. So some of those big progressive agenda items that I think they campaigned on are probably not going to come to fruition, given those numbers, obviously, like the Medicare for All, the public insurance option, or the Affordable Care Act. Those are probably not going to get through a House and Senate with those tight of margins. So even though the Democrats, I think, can claim a mandate, if you will, I think sort of their progressive agenda that they had planned is going to have to be reined in a bit. Again, with those tight margins, what we're going to be seeing and what we're going to be looking at is who are those moderate senators that can kind of sway the agenda voters. Most things require 60 votes. A 51 margin, there are things that require 51 votes, but most need 60. But if you were looking for those 51 votes, you have Senator Lisa Murkowski and Susan Collins and Mitt Romney, who have tended to be the moderate Republicans who are not afraid to buck their party and side with the Democrats. And then on the flip side, you have Kristen Sinema and Joe Manchin and the new Senator Mark Kelly of Arizona, who've done that for the Dems, right? They're not afraid to switch and buck their party. So that's going to mean that the negotiations in the Senate is going to be very tight. And Senator Schumer and Senator McConnell are really going to have to rein in their caucus. We'll go to the next slide. So we have Chuck Schumer, as I just mentioned. He's now the new Senate Majority Leader, replacing Mitch McConnell. Mitch McConnell now replaces Schumer as the Senate Minority Leader, and there's no change in the House leadership. Nancy Pelosi is still the Speaker of the House, with Kevin McCarthy as being the House Republican Leader or the House Minority Leader. So what is Congress looking like, or what are they going to be focusing on in 2021? Obviously, COVID is still first and foremost on the front line. It's what President Biden has been focusing on. It's what Congress will continue to focus on as well. They were able to pass the latest stimulus, COVID-19 stimulus, which was about $1.9 trillion in relief. That was passed through a mechanism called budget reconciliation, which needed only needed 51 votes, not the standard 60. So that's how the Democrats primarily were able to pass that through, again, very slim margins. The next up, what they're focusing on now is infrastructure package, or what the president and what Senator Schumer and Speaker Pelosi have deemed sort of number 2 related to COVID, is this infrastructure package, which would be about $2 trillion in funding. So that's $2 trillion above the 1.9 they've already spent. And this could actually be passed under a second budget reconciliation package, which is a little unheard of. You're usually budget reconciliations are only done once a year. It can only be done through the budget process, which, again, the budget process happens once a year. But the parliamentarian has said that the Democrats can actually go back and amend the first reconciliation package and then go and then do a second budget reconciliation package. So that's what they're currently working on. Again, the Affordable Care Act, or the ACA improvements, is something that I think you will see the Democratic House and Democratic Senate likely to work on with the Biden administration. Again, unlikely to secure the passage for the more sort of progressive policies of that public health option or the Medicare for all, but I do think you'll see some tinkering around the edges on the Affordable Care Act. Telehealth, I think you're going to see the House and Senate work on some of the COVID waivers and trying to make these permanent extensions that they've been extending permanent. So I think that's also on the forefront. Maybe some flexibilities on as the public health emergency expires. I think you'll see some flexibilities in seeing what they can continue to kind of reauthorize or keep going, and then sort of seeing CMS expand sort of valuable or virtual things, and prior authorizations, or authorizing providers to do things, for example, like the pharmacist being able to retail pharmacists being able to vaccinate folks for COVID-19. And I think you'll see some expansion on non-rural patients, sort of the rural health piece as well. And then, of course, drug pricing. That was the big talk of town in the last Congress. They got very close to getting something done in a bipartisan fashion, and at the 11th hour, it fell apart. There's been discussions on both sides of the aisle and both sides of the Capitol about redoing drug pricing or looking at that again. So I think while the large-scale change or government negotiations and international pricing may not be something that they can get through, I think you'll see some other sort of smaller negotiated bipartisan agreements that were included in the package for last year. But you're going to see that happen right after infrastructure. And then the last thing is, and it's not on the slide, is the annual appropriations process, which has to happen. That's also going to take up the time for Congress. And then you're going to see this slide looks very similar to the last slide. And that's because, as I said, you have all democratically led House, Senate, and White House. They're going to sort of be locked in step, right? So you're going to see some of the same things. Again, I think President Biden has made very clear that COVID-19 pandemic is his biggest priority. So these are some of the things that you're going to see from him, ensuring that the COVID-19 testings are still widely available, continuing to ensure the safe and the safety of the COVID vaccine. We already know about the news of the J&J being at least halted for the short term, making sure that those vaccines that are getting out to the public are still free. Continue to implement the mask requirements, whether they need to tailor lockdowns or rolling reopenings. Like, these are all things that he's continuing to focus on as it relates to the COVID-19 pandemic. Again, looking at the infrastructure package, a little bit of details here. So Biden's proposal, what he has said about his proposal is that it's a once in sort of a generation investment for for the U.S. We haven't had this sort of opportunity to do this massive infrastructure package in a generation. And, while it's, like I said, $2 trillion, his idea is that the proposal would be paid for by a slew of tax increases on corporations. So this is where you're going to see the fight between Republicans and Democrats. The proposal seeks to spend hundreds of billions on what are traditionally considered infrastructure projects, so bridges, roads, those sorts of things. But the piece in here that I wanted to highlight for you all is that the package does also include about $400 billion towards expanding access to home or community-based care for the elderly and people with disabilities. So you don't typically see a healthcare portion included in what is an infrastructure package. And again, that's about $400 billion. Again, looking at ACA, shoring up sort of the Affordable Care Act, not to be redundant, I don't think you're going to see, the Medicare for All sort of thing. The reallocating of funding for the Affordable Care Act Navigator program, fixing or expanding open enrollment periods. I think you'll maybe he's done that once already through an executive order, but I think you could see him expanding upon that. And then rescinding and rewriting sort of the Trump era regulations, which we've already seen. He's frozen all of those regs that have not been finalized. And so I think you'll continue to see some of that. Working on health equity is a big key to what President Biden has put on his agenda. And then lastly, but not least, and it probably should have been led with, is cancer research. We all know that curing cancer, ending cancer as we know it, has been the thing that President Biden has been on talking about the most, even as vice president, with the moonshot effort that he started at the NIH. He's made no bones. He said it. He's going to work on it. This is his passion. This is what his legacy will be. And so he's going to be focusing on cancer research. And so I think it's something that we, Brooke and I, and the Public Policy Committee will continue to monitor and try to engage on as it moves forward. So I think that I'm going to kick it off to Kathyrn, who's going to initiate or start off with the priorities.
Thanks, Jeremy. So yes, we've focused on some of the Congress and presidential priorities that are going on, but we want to also talk about what are some of HOPA's priorities. And what are we focusing on within HOPA as far as some of the federal policies? So oral chemo parity, you've heard it a couple times already through this presentation, and it's been something that we've talked about over the years as well. So it's not really something new that we're hearing about, but it's something that we're still trying to push forward. And I think that we've all seen the explosion of oral chemo drugs coming forward over the years. So this is something that is very of much of interest to us as an organization. We also know that there's a huge disparity between the oral and the IV chemo coverage, and that could really create a barrier for care for patients. And so we want to make sure to address that. Over the years, there's been numerous times when this Cancer Drug Parity Act has been introduced and reintroduced. And on behalf of the Public Policy Group, I want to thank Jeremy, because I know he's been part of the history of this for many years and is well versed with all of this. But this is something too that we're sort of waiting to see what the next steps are going to be with this moving forward. Obviously, there's a lot going on as far as healthcare with COVID going on right now. So it hasn't been reintroduced at this time, but there are also 43 states, including DC, that have passed oral chemo access legislation. So there is some movement being done on the state levels, and then we'll be focusing on this on the federal level. Another big topic is site of care. And if any of you had the chance to attend the breakout session yesterday, led by Dr. Stephanie Kang from UNC, it was a fabulous job discussing some of the concerns about should we be having some of these medications administered IV or at home or not necessarily just IV, but COVID really has sped up this conversation because so many things were moved to home care during the pandemic. But there's still a lot of things that we sort of need to pause and go back and really evaluate. And one of the big themes that we heard, especially at the breakout session yesterday, was the focus on patient selection. Who are the right patients for some of this care that might be at home? And also, who's making that selection? Is it the oncology care team versus the patient's insurance company steering that? So we do want to make sure that we have a voice at the table as well. ONS and ASCO have both put forward some of their own statements as far as their perceptions on what site of care steering should look like. And so we're also having HOPA work on to respond to the site of care concept as well. We had a lot of great input yesterday at that breakout session. And I think the other thing too is those of you who are attending tonight, if anyone is really passionate and interested in helping to define what we think this site of care issue brief should look like, please feel free to reach out to the HOPA staff or myself. We want your input on this. And I think this is really one of our next key items to focus on is the site of care, because it's a hot topic that's been going on because of the pandemic. Oops. And now I'm going to pass it over to Mark.
All right, well, tonight we'll close on with some of the COVID impacts that took place throughout the course of the year. So first one that we'll touch on is around prior authorization. Prior authorization is not something that I think any of us would really choose to deal with on a daily basis if we had a choice. But once COVID came, it became even more burdensome to deal with, because now you had folks trying to work remotely, and just remember all the new nuances we had to deal with as this was coming through. So in March 2020 last year, the Community Oncology Alliance sent a letter to the White House requesting that all insurance companies waive prior authorizations for cancer patients to try to take one step out of the equation of treating patients. And then in April of 2020, CMS issued guidance for Medicare Advantage organizations and Part D sponsors, asking them to relax or waive prior authorization for patients. So interesting spin on that one. Certainly, if you work in a health system, COVID distribution has been something you've talked about, or maybe very much so been involved with. But recalling back as the vaccine was becoming a reality, a lot of logistics around who should get it first and how are we going to allocate this scarce resource, and then trying to figure out where cancer patients fit into that, given that there were still so many unknowns about the vaccine. And then we touched on the COVID-19 vaccine principles that were created by the group to try to advocate for some of the key points that needed to be considered as we were determining where the vaccine should go and how we needed to handle it. And then the last one's a pretty significant one that took place throughout the year, but as health systems had to adjust and a lot of services were put on hold, it was noted that between March and September of last year, there was a 23% reduction in cancer diagnoses. So clearly something that some of us are still catching up on, but had a huge impact on cancer patients from being able to be treated anything similar to what they would have in normal conditions. So with that, we will open it up to any questions that anyone has in the group.
Yeah, and while we're waiting for questions, Mark, I thought I would just update the audience a little bit about what the Coalition to Improve Access to Cancer Care is doing around the oral parity issue that Kathyrn highlighted. We haven't reintroduced, as Kathyrn mentioned, the bill that was introduced in the last 3 Congresses, and the reason being is the way in which this bill was written. So this bill, again, addresses those patients are those folks who are on federally regulated health plans or ERISA plans. And that's made up of those on group plans, self-insured, and those that are on the exchanges, and make up about 220 million covered lives. So as Kathyrn mentions, and this slide indicates, there are 43 states plus the District of Columbia that have passed state parity laws. Those are that have state regulated health plans. So that's great for those that are on state regulated health plans, but a majority of Americans are on federally regulated health. And so that's why we are doing this federal bill, again, to make sure, as Kathyrn said, that there's no discrepancy or parity between those that have IV chemotherapy and those that could be on oral chemotherapy, and trying to reduce that high out-of-pocket cost for those patients and the burden for those that could just take a pill at home as opposed to sitting in an infusion center. So the mechanism by which we get to those ERISA plans for the last 3 Congresses has been that we don't actually amend ERISA, because by amending ERISA, that puts us in 3 different committees in the House. That's the Energy and Commerce Committee, the Ways and Means Committee, and the Education and Labor Committee all have jurisdiction over ERISA. Ed and Labor does group. Ways and Means does exchanges, and E&C does self-insured. So instead of doing that, we found a place in the Affordable Care Act that we can actually amend ERISA by amending the Public Health Services Act. That would only put us in the Energy and Commerce Committee. So that's what we've been doing for the last 3 Congresses. Well, some of you may or may not have been tracking the surprise billing issue that was of much debate in the last Congress and was finally passed at the beginning of this year, or at the end of last Congress. But the surprise billing, there was a lot of turf battles between the chairman of those 3 committees as who has jurisdiction over what. And there were a few bills, 7, that sort of used the mechanism that our bill was using. So Speaker Pelosi called the 3 chairmen in, said, fix whatever your problems are, and the gentleman's agreement is that they would no longer allow bills that touch ERISA to bypass any of the other committees. So you can no longer use that public health services sort of piece the mechanism that we've been using. So we've been struggling as a coalition, and HOPA, we've been talking about, well, how do we do this? Because we know that it's going to be an uphill battle to try to get a bill through 3 committees. We've tried it before and we were unsuccessful. So what we're thinking about doing and what we're contemplating, and it's taken us quite a bit of time to get all of our research in, is that there's a bill out there on step therapy. Again, some of you may or may not be tracking step therapy. Well, step therapy is choosing, their bill only addresses group plans. So that only puts them in Ed and Labor, the Education Labor Committee. So we were thinking, well, can we draft our bill to only do group plans, which is the largest of those 3? Granted, we don't want to leave any covered lives behind, but we also want to make some headway. And so we are able to amend, or we're able to get to those group plans by only going through Ed and Labor to fix this. Again, it would fix we would be leaving about 40 million lives behind. So 40 million covered lives are in the self-insured and the exchanges. So the larger chunk is the group plans. So this is what the coalition is debating. We're actually having conversations. I've had conversations with ACS Can today, ASCO, and so we're moving these discussions along. But we need to have some finality next week because we do want to reintroduce and we have some homework to do. And so I just wanted to give folks this is sort of the behind the scenes sausage making that happens in Washington. It actually is impacting one of HOPA's major issues that we've been working on for about a decade. And it does have some repercussions. The Public Policy Committee has decided that they would support doing the group plans, even though we would be leaving about 40 million covered lives. But anyone who's been working in Washington knows that in order to legislate, you have to do it through incremental change. You never really get everything you want. We've seen it with the Affordable Care Act. And I just said what the Democrats in Congress and what President Biden wants to do is continue to tinker around the edges of the Affordable Care Act. So it's a building process. And so if we can get the majority of covered lives on group plans, this fixed them, I think we could get the other 40 million to come along. And we had some time and how many questions. I just thought I would sort of give you a little bit more sort of inside baseball about what we've been doing. And again, HOPA is on the steering committee of this coalition.
Okay, so it looks like we had one question just to clarify that the correct bill number of the Cancer Drug Parity Act, as it was introduced a few years ago, was HR 1730 and then S 741. When it's reintroduced, it will get a new bill number during this Congress. But as if you want to go back and read it or look at it, that is the correct citation. But it looks like we don't have any more questions in the queue here. If you do think of any questions or you want to ask more details about any of the topics that we covered tonight, please feel free to reach out to advocacy@hoparx.org. And I can get back to you with answers to any of your questions there. I'll also encourage you, if anyone is interested in any of the topics that we discussed tonight or interested in policy in general, the VAC opened today. So please apply to be on the Public Policy Committee. And we would love to have you. And it looks like a few more questions actually just came in. So the first question is, what can members and their organizations/employers do to help with legislation and letter writing? Is that an option? So does anybody want to take that question?
Sure. Yes, there is a mechanism. HOPA has a mechanism on their website that members can, in fact, engage in what we call letter writing campaigns or issue campaigns. There actually is not one active right now. Brooke and I were actually just talking about this last week, or it might have been earlier this week, because as I had mentioned, the appropriation process is underway. Most of our coalitions, those that I mentioned, OVAC and HIPNIC, have finalized the appropriations requests for this year for the funding for those programs that we support. And so we are going to be putting together an action alert, if you will, that will be posted on the website for folks to go to. And really all you need to do there is you access it by typing in your zip code. You don't even need to know who your legislators are by name. You just have to know your zip code. It'll auto-populate who your members are. It will describe the issue and then the letter, and then you can just hit send. We always encourage you for those sorts of letters, though, to insert a little personal flair, if you will. It makes it a little bit more distinctive. But as these bills and these other things become, so once the oral parity issue bill is reintroduced, there'll be a campaign for that. So there is a mechanism that HOPA has for its members.
Great, and it looks like we actually got two more questions about the same issue here. So guessing the pharmacist provider efforts are on the back burner, and is JCPP working on provider status for pharmacists?
Okay, so I'm not going to steal Brooke's thunder, so I'm going to go ahead and let Brooke start with this because she had breaking news for me this morning, and so I'll let you, Brooke, go ahead and take this.
Yeah, so the provider status efforts have been something that pharmacy has been talking about for years, and getting pharmacists paid for their services and recognized as providers. Earlier in the year, JCPP had some conversations, and it seemed like the best way that it was going to go to get provider status, actually supported, was to do it at the state level and to have states work on campaigns and pharmacists in your individual state work on campaigns for provider status. However, I was on a JCPP call this morning, and the government relations staff from the other pharmacy organizations let us all know that a provider status bill will be reintroduced into Congress next Thursday. That bill is going to have the same text as the bill as in the 115th Congress, so when it was reintroduced the last time, and they are trying to do it concurrently in both houses. So the House of Reps has 2 senators who are backing the bill right now, and then has two representatives who are backing the bill, and then the Senate has ChuckGrassley as the main person introducing and backing the bill. And so we are seeing provider status as of this morning coming back into the forefront and really pushing on this issue. And I know they will try to be playing this off of COVID and the incredible and very important role that pharmacists have played during the COVID-19 pandemic, and the fact that pharmacists are one of the main reasons that so many people were vaccinated so quickly. And so they're going to try to use the clout that the pharmacy community has from COVID-19 to try to push this provider status effort forward.
Yeah, it was surprising. ChuckGrassley was the reason why it was not introduced in the last Congress at all is because ChuckGrassley was not in favor of it. So Brooke not being a part of any of the backdoor conversations, I'm very interested in knowing how we've got to this point, of it being introduced next week. But it's good news. It's something that I think, again, HOPA had. We used our advocacy muscle on in the 115th Congress, and so I would imagine if it's not any different than what the 115th was, I'm certain that we will be moving that forward as well.
Yeah, and just a follow-up question: should HOPA be writing a letter and having patient stories incorporated in that letter? I think it would be interesting for HOPA to write their own letter. I'm sure JCPP and the JCPP organizations will all have letters, and this is going to be a massive campaign together. So we will take that back to the Public Policy Committee and put it out to the committee what they think is best. But I think this is going to be an all-hands-on-deck effort to try to get this passed, since we now have the opportunity to do so. Okay, it looks like that was our last question here. So I'm going to go ahead and throw it back to Dr. Hamm to just close us out.
Well, thank you everyone for joining us tonight. Hopefully this was informative. Like Brooke said, it's an interesting area and always looking for more people to get involved. So if it is something that's of interest, please consider the VAC, and can speak from my own experience. I've learned a lot from being on this group, and it just puts a different spin on what I see in my day-to-day experience. So thank you all again for joining, and have a great evening.